The fifth of the cranial nerves, trigeminal, motor, somatic motor, and sensory. And let us first take a look at its sensory distribution. This is obviously a schematic drawing of a person's face. And we always consider the individual divisions of the trigeminal nerve independent of one another. All three of them, V1, 2, and 3, all have sensory distribution on the face and elsewhere as well. This is the distribution of V1. It is not enough that you know this distribution, but for this particular, listen, for being a doctor, it's enough you know this distribution. But for this course, you also have to know the names of the nerves that do these different regions, all right? And here they are, all of which names should be familiar to you. The actual eyeball, and most importantly, the cornea of the eyeball, is done by the nasociliary branch of V1. The nasociliary branch terminates by dividing into an anterior ethmoidal and an infratrochlear. The infratrochlear comes out and does a little bit of the medial part of the upper eyelid and does the skin over the bridge of your nose. The anterior ethmoidal pierces the anterior ethmoidal frame and enters the ethmoid air cells. It actually does ethmoid air cells. I can't draw, that's a non-surface sensory function, ethmoid air cells. It does a bit of the superior aspect of the nasal septum and the lateral nasal walls, the superior aspect of the lateral nasal walls, and then the anterior ethmoidal nerve emerges between the lateral cartilage of your nose and your nasal bone as a nerve called the external nasal. So that's the terminal branch of the anterior ethmoidal nerve, and that does the skin along the entire dorsum of your nose and a bit on the sides as well. Supratrochlear and supraorbital are the two nerves of the forehead. And lacrimal does a little bit of skin right here on the lateral aspect of the upper eyelid. Here's the V2 distribution, or what the skin that V2 covers. You probably don't know as much about this as you do V1. The nerves, the cutaneous branches of V2 are the most important, the infraorbital, which that you do know a bit about because you dissected it coming out of the infraorbital foramen. And that does most of this region. There is a little bit of skin on the lateral surface of your bony cheek done by a branch called the zygomaticofacial. And maybe you do know about the zygomatic branch of V2, which enters the orbit and then leaves it again through a foramina or a foramen that splits into two and sends one branch out to the skin over the lateral aspect of the bony cheek, and then the zygomaticotemporal nerve, which is a tiny nerve that does some skin just behind your orbit, on the side of your temple, just behind the orbit. Much of the sensory function of V2 is actually not expressed on the skin. V2 handles most of your nasal cavity, handles your palate, and handles your upper teeth as well, through branches that never do emerge on the surface of the skin. V3, which you have did dissection of just on Wednesday, its branches are the auriculotemporal. I know we have seen the auriculotemporal, which does a bit of the upper portion of your external ear and the rest of the temple, not done by zygomaticotemporal. The buccal branch, which sometimes we are successful in finding, more often not, which does the fleshy cheek, the skin over your fleshy cheek, and the mental branch, which you all did see, which is the terminal branch of the inferior alveolar, which does the skin over your chin, your lower lip, and the anterior half of the body of the mandible. Again, V3 has a lot of non-cutaneous sensory representation. It does the anterior two-thirds of your tongue, does all of your lower teeth, and have I forgotten anything else that it does? Probably I may have, but those are the important ones. Oh, it does the mucous membrane on the inside of your fleshy cheek, obviously, and the gums over your lower teeth, in association with your lower teeth. This part of the face, the angle of the jaw, the skin over the angle of the jaw, and the lower part of your ear is not done by the trigeminal nerve. Who would like to tell me what does do that? C2 is correct. There's a name to the branch of C2, which we dissected. Yeah, the great auricular. The great auricular, which is C2, carries C2 and C3, but this part of it's mainly C2, does this angle of the jaw. The skin over the angle of the jaw in the lower part of the ear. Here is our pal.
The next cranial nerve is the fifth, the trigeminal, and this has sensory, V1, V2, V3, and motor components, V3. It's important to recognize the territories of these sensory components. V1 involves a distribution around the forehead and on the side of the nose. V2 is mainly the cheek, and V3 the chin. Be careful when applying the stimulus not to touch the angle of the jaw, as that is outside the territory of the mandibular branch. Enrica, I'm going to touch you with this cotton ball. I want you to close your eyes, and every time you feel the stimulus, just say yes.
Yes. Yes. Yes. Yes. Yes. Yes.
Is that equal on both sides?
Yes.
And you can see it's good to vary the rhythm a little bit so the patient doesn't fall into a steady pattern of just saying yes when they anticipate the stimulus.
So you don't test all those different branches that I mentioned. You go right into the middle of the distribution area of these divisions, and you test in the middle of that distribution area.
Pain and temperature is assessed with a pin. The pin should be a disposable pin, or you can use a tongue blade that you've broken in half, but these should not be used from one patient to another. The patient is asked to close their eyes, and they are either touched with the sharp or the dull end. Enrica, please tell me, is this sharp or dull?
Sharp. 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 Dull. Sharp. Sharp. Sharp.
Did that feel the same on the two sides?
Yes.
Facial sensation can be assessed very objectively by performing the corneal reflex. The afferent limb of the reflex is V1, or the ophthalmic division of the trigeminal nerve. The efferent limb is through the seventh facial nerve. The stimulus is a cotton ball formed into a wisp, and the stimulus is applied to the cornea with a direct stimulus to the cornea, and the eyes are observed to see both a direct and a consensual response. When performing the corneal reflex, you have to explain to the patient what you're going to do. Enrica, I'm going to take this cotton ball and very gently touch your eye with it. Okay? What I want you to do is look off into the distance, and it's important when you do deliver the stimulus that you actually touch the cornea and not just the sclera, because it is the cornea that is the most sensitive. So look up and to the left. And I want you to watch both of Enrica's eyes as I do this. It's good to rest your hand on the face so that you're nice and steady and deliver a quick stimulus. And you can see that Enrica blinked on both sides. So there's a direct and a consensual response.
Yeah. So that is our second consensual reflex, the first one being the pupillary light reflex, and now we have the corneal reflex as a consensual reflex as well. Both sides respond by blinking even though only one cornea is touched. Now, the using of the pin and the dull and the sharp thing has nothing to do with testing the trigeminal nerve, the part you're going to see, the peripheral part. I kept that in for the sake of completeness, but that really tests the different pathways that pain and touch have in the brain. They all travel into the brain but via the trigeminal, and then they diverge. And so you're testing really brain stuff when you test the ability to distinguish between a painful or a pinprick versus the dull side of things. That's not really a test of the trigeminal nerve per se. The corneal reflexes, unless Katie, you just came in. Katie, does Drew Wackett make you do a corneal reflex on people?
Yeah, it's more It's not quite as detailed as this, but
Yeah, you hardly ever see a doctor do a corneal reflex. It just annoys the patient far too much. And so you just, if they can pass the rest of it, you just move on from there. Okay. Now, one thing I do want to talk about is this condition of the trigeminal nerve called tic-douloureux. A tic is an uncontrolled spasm, generally, of a facial muscle. You know, if I'm sitting here and I'm going like that all the time, that would be called a tic, a facial tic anyway. Tic-douloureux is, and often tics are related to muscular problems and the nerves that innervate them. But tic-douloureux is a tic that is not related to a muscular problem. It's related to the fact that people disagree about the cause of this, but it's related to the fact that sometimes different divisions of the trigeminal nerve, right, it's also called trigeminal neuralgia, become extraordinarily sensitive to any stimulation, so that a little brushing of your cheek will suddenly send radiating pain from the entire distribution of V2, for example. And the person responds, the cheek is brushed with lightly or even a wisp of air sometimes, and the person responds by going, ooh, it's terribly painful. So that's the tic, is the response to having this horrible excruciating pain radiating from the distribution of one of the divisions of the trigeminal. The V2 is the most common one. You can get isolated tic-douloureux along the mandibular division or the ophthalmic division, or you can even get combinations of two of them. I don't know if there's any one where three occurs. Yes?
So does that mean that V2 is responsible for the pain pathway, or no?
Well, each one of these brings back pain. The trigeminal nerve brings back touch and pain. It's just that when it gets to the brain, there's a divergence and going to different nuclei, which tell you about pain or touch. So every division of the trigeminal carries back information about touch and pain from the region of its distribution. These things are treated medically generally to start with, but there is evidence, not just a school of thought, there's evidence that the cause of tic-douloureux is existence of a tiny blood vessel bouncing up against or pulsating up against one of the divisions of the trigeminal nerve in the middle cranial fossa. And if it cannot be treated successfully medically, it has been successfully treated by going in surgically and putting a little cotton wedge actually between this pulsating blood vessel and the actual division on which it's beating, and that seems to resolve the problem. The neurosurgeons and the neurologists tend to take different views on this. The neurosurgeons believe that's how you should treat it, and the neurologists tend to believe you should treat it with medications. All right. V3 is the one and only division of the trigeminal that has somatic motor in it. And some of you, I tried to show some of you a bundle, which I said is the somatic motor root of the trigeminal nerve, and show you it going on. We never saw where it joined V3 because it always joins V3 distal to the trigeminal ganglion, but I picked out something. I said, this is probably it. So it has a separate root. The trigeminal nerve comes out of the brain. There's two separate roots, the sensory root and the motor root. And the motor root joins V3 distal to the trigeminal ganglion. And it innervates 8 muscles. There are some that move the jaw, the anterior belly of digastric, lateral pterygoid, masseter, medial pterygoid, and temporalis, just put here in alphabetical order for no other logic to that. And then there are 3 muscles that it innervates which do not move the jaw. Now these are the muscles innervated by V3 are all referred to as muscles of mastication, muscles of chewing. But in fact, 3 of them don't move the jaw at all. Now, one of them is involved in mastication. I'll tell you about that in a second. But 2 of them aren't even involved in chewing or anything to do with the jaw, really. Now, let's cover the 3 that do not move the jaw first, mylohyoid, tensor tympani, and tensor veli palatini. But I want to, before I do that, point out to you something, if you've read ahead, you know already about, which is probably the most important principle in all of anatomy, which I named after myself because of its importance. And that is how to memorize some innervations of some small muscles of the head and neck. And this is, Stern's law is a or tripartite law. So I'm only giving you the first part now. The second, third parts, if you haven't read ahead, you'll have to wait till next week to hear. But the first part is inviolable, never violated, ever. All of the muscles of the head with tensor in their name are innervated by V3. Now, sadly, there are only 2 of them. All right? So it's not going to help you like memorize 17 muscle innervations. But those 2 are tensor tympani and tensor veli palatini. They're all the muscles of the head with tensor in their name. They're all innervated by V3, and there's no violation of that. Let's take a look at the 3 muscles that do not move the jaw innervated by the V3 or mandibular division trigeminal. One is the mylohyoid. You've seen it. It's a muscle that, for all intents and purposes, just is a hammock-like structure which bridges from the inside of the body of the right mandible to the inside of the body of the left mandible, bridging across like this. It's got a raphe down the middle, just like your levator ani has. So these are really 2 muscles. There's a right mylohyoid and a left mylohyoid joined at the raphe. But it is really just a sling or a hammock below your tongue. And its main function in life is, in fact, to cause the floor of your mouth to become semi-rigid so that when your tongue swells up, as it does in the process of swallowing, we'll talk about that a little later, but in the process of swallowing, it's necessary for your tongue to swell upwards and contact your palate. That when the tongue tries to swell, that is directed upwards to your palate and not downwards to where it can do no use at all. So the mylohyoid provides a semi-rigid floor of the mouth, allowing the tongue to swell upwards and contact your palate. In fact, it is probably also involved in a way that's more complicated to explain than I'm willing to, in chewing, because if it contracts unilaterally, it helps the tongue to push food to the opposite side and keep the food in between your teeth on the opposite side. So, yes?
Do you think, like biologically speaking, we developed that whole ability to move food from one side to the other because our teeth go really early, like before we had dentists? I mean, I know.
So the question is, do I think people chew on one side, or all animals, all mammals, have one side and then the other so as not to wear one side down entirely?
You know, we get cavities, and then, you know, back like in the Middle Ages, people had cavities, so they chew on one side. Like they'd have like 3 or 4 good teeth, you know?
Oh, so you mean well, every mammal chews on one side and then the other. So it's not cavity-related event. I mean, obviously you want to have as much chewing surface as you can because your teeth are going to wear down. So you want to use one side and then the other and back again and eventually wear them down symmetrically. It is nice that we are able, if you have terrible pain on one side, to chew on the other side, but I don't think that's why it occurred. But anyway, it does help the tongue to position food between the teeth on one side or the other, so to that extent it's involved in mastication, but mainly for swallowing, really. Tensor tympani, a tiny little muscle you will see, if you're lucky, when we do the ear on the last day of head and neck dissection, do the inner ear. On the last day of head and neck dissection, you will chip away all this bone here and look for these tiny little bones of the ear, but you'll see a little tendon. Almost everybody sees this little tendon running from a muscle that you probably will not be able to visualize because it's minute, really. I've seen, well, sometimes you chip away the bone here, you can see it. It's called the tensor tympani. The muscle has sits in a bony canal just above the bony portion of your eustachian tube. And its tendon makes a 90-degree bend and inserts on this bone, which is called the malleus, which is a bone that attaches to your eardrum. We'll learn more about these obviously later in the course. The tensor tympani, when it contracts, pulls on the malleus, and the malleus is attached to the eardrum. So it pulls on the eardrum and dampens the vibrations of the eardrum. Makes the proper name for the eardrum is the tympanum. That's the anatomic name, tympanum. So tensor tympani is a tensor of the tympanum. All right? Dampens vibrations. For many years, it was thought that this is part of something called the acoustic reflex, which is a reflex that when very loud noises encroach on you, something has to dampen the amplitude of the sound so it doesn't damage your cochlea. And there is a muscle that does that we'll learn about on Monday. For many years it was thought that this did that too, but in humans it's pretty clear that it doesn't do that. It does not contract when very loud noises approach your ears. And in fact, no one knows for sure what it does do in humans, other than the fact that it is, and I can't remember the evidence for this, but I know I read it somewhere. I don't know how they got it. It does contract when you speak. And the belief is as following. First of all, when you can either do this now or leave, you tend not to realize how loud your own voice is to yourself when you are speaking. And the way you can demonstrate this yourself is, count to 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All you have to do is put when you walk out of here, you'll do this. All you have to do is put your hands here to block the sound from coming to your ears, and you'll be. It's remarkable how much quieter your voice gets if you just do that. And so your own voice sounds very loud to you when you speak. Now it is known that the low frequency components of any sound mask. If the amplitude is high enough, they mask the higher frequency components. And most of the content of speech is in the high frequency components. So if the low frequency components of our own speech is making it difficult for us to understand or hear the high frequency components of our own speech, it would be good to have something that dampens the low frequency components so we can better understand what we are saying ourselves. And you're always monitoring what you say. So the feeling is that the tensor tympani contracts when you speak to dampen the amplitude of the low frequency components that get to your cochlea so that your cochlea is better able to process and discriminate the higher frequency components of your speech, and you're better able to understand yourself, what you are saying. Maybe that's true, maybe it's not, but it's a good explanation.
I have a question. Is it normal to have voluntary control over that?
Is it normal to have voluntary control over the tensor tympani? And I do not have voluntary control over it, so it must not be normal. Right? I don't know. You think you do, Bryce?
Well, yes, I think so, but I'm not.
I don't think it's impossible. I mean, I certainly don't see why it would be impossible to have voluntary control over it. I just don't know. I didn't know anybody who ever claimed to. But I mean, it's a striated muscle. Striated muscle, there's no reason it shouldn't be under voluntary control in the same way that any other muscle innervated by V3 isn't. And the other tensor muscle is a muscle called the tensor veli palatini. Dr. Dagum had mentioned this in his lecture as well. I don't know at that time if you knew much about it. Now, this is meant to be a coronal section through your skull with everything removed except the cartilaginous portions of your eustachian tube and the mucous membrane, which forms the mucous lining, the mucous membrane lining of your eustachian tube. These cartilaginous portions of the eustachian tube are sort of an inverted J-shaped structure, and this thick stuff here is meant to be the mucous membrane which surrounds the actual air space of the eustachian tube. The eustachian tube is an air-filled space running from the back, from your nasopharynx, behind your nasal cavity, to your middle ear. And it is very important for middle ear functioning to have air there. And Dr. Samara will give you a lecture when he talks, one of the clinical guest lectures, when he talks about middle ear problems and how bad things happen if air cannot get to your middle ear. And so this thing, tube opens up repetitively to allow air to exchange and equilibrate the pressure between the external environment that you're in and the pressure inside your middle ear, and also to allow things to drain from your middle ear, fluid and things like that drain through the eustachian tube. And the eustachian tube is primarily opened by a portion of this muscle called tensor veli palatini. There's another portion of the muscle sort of indicated here that's not attaching to the eustachian tube, which just arises from bone. But a few of the fibers, some of the fibers of the tensor veli palatini arise from the outer membranous layer, membranous lateral wall of your eustachian tube. Eustachian tube is said to, the cartilaginous, the non-bony part of the eustachian tube is said to have a medial cartilaginous wall and a superior cartilaginous wall, but a membranous lateral and inferior wall. And so some of the fibers of tensor veli palatini arise from the membranous lateral wall of your eustachian tube. And when they contract, they will pull open the eustachian tube and allow air to pass freely between the nasopharynx and your middle ear. Now they contract at the same time all the rest of the muscle contracts. And the rest of the muscle, which arises from bone, all the fibers, whether they arise from the lateral wall of the eustachian tube or from bone, they all converge on a tendon, which turns around a little thing called the hamulus of the pterygoid plate, which you should find on a skull if you haven't found one yet. And that tendon then spreads out into your soft palate, forms what's called the palatine aponeurosis. And the muscle gets its name for the fact that the pull that it exerts on the soft palate is from side to side. It gets rigid and resists anything that would push upward. So this muscle, tensor veli palatini, pulls on the sides of your soft palate, makes that soft palate rigid, as much as soft tissue can be, to prevent things from passing upwards into your nasal cavity when you swallow. That's its real function. It's a swallowing muscle, tensor veli palatini. And every time you swallow, you contract this muscle. And every time you contract this muscle, generally some of the fibers that arise from the lateral wall of the eustachian tube contract along with all the rest of the muscle and open up your eustachian tube. So that's why when you go up into an airplane and you ascend and you start to feel the pressure build up in your ear and you want to equilibrate the pressure, the flight attendant will tell you, chew gum, suck on candy, not because the chewing or the sucking makes any difference. It's that if you chew gum and suck on candy, you generate lots of saliva and you swallow the saliva a lot. And it's the swallowing which eventually, not always, because sometimes you can just use these fibers which arise from bone. You don't have to always use the fibers which arise from the lateral wall of the eustachian tube. But if you do enough swallows, you're bound to get one or two which bring in the whole muscle, and that will open up your auditory tube. Obviously, another very good method for doing this, if you haven't experienced it at this very moment, you will soon, is yawning. Yawning causes your palate to get tight. It's actually, for me, more effective at opening my eustachian tube than swallowing is. So that's what the tensor veli palatini does. It is mainly a muscle of swallowing that plays a very important role in equilibrating pressure between the middle ear and the external environment. Now, these three muscles, mylohyoid, tensor tympani, tensor veli palatini, they all perform really important functions. And yet, when you look at the literature that describes people who have damage to their trigeminal nerve, you can never identify a symptom related to paralysis of these muscles. And it's surprising. People with trigeminal nerve injuries don't have particular trouble swallowing. They do not, even more so, they don't have notice any difficulty with hearing or anything like that. And most surprisingly to me, they don't have problems with their middle ear functioning either. And I don't know why that's the case. But they don't. And Dr. Dagum, on the other hand, mentioned, I hope you may recall, young children who are born with cleft palates always have problems with their middle ear. And the reason is presumably that without this firm attachment here, when this muscle contracts, the muscles just separate there, so there's not a firm basis or base on which they can pull. Therefore, they're ineffective in opening the auditory tube, and so people with children born with cleft palates almost always have problems with their middle ear. They accumulate fluid, and they get infected. And he told you, and it says in clinical sidelights, you have to treat children with cleft palates with these myringotomy tubes, with tubes which actually pierce the eardrum and allow air to pass in between your middle ear cavity and the external environment with no barrier. But it's also the case, and this is in clinical sidelights that he told me, that even if you don't treat a child with cleft palate, and you don't repair their palate, once they get to be 3 or 4, they don't need the myringotomy tube anymore. they seem to do okay anyway after that. And that sort of goes along with the fact that people who have a paralysis of the muscle on one side don't, as an adult, don't seem to suffer any problems from it. So these are just sort of mysteries to me, but maybe you'll discover the reasons for it in your careers. So none of these three muscles seem you don't seem to suffer as an adult human if you paralyze any of these three muscles.
Jack?
Yes?
But I remember someone telling me that in infants, the auditory tube is more or less horizontal,
That's right.
and then it starts to tip down as you get older.
That is exactly true. That is the explanation that is offered both in clinical sidelights and, that as you get older, your auditory tube does decline, or it runs from runs inferiorly, and therefore drains more effectively. And so it drains fluid more effectively for that reason. I still don't understand how, if you can't open it, it works. There may be, actually, I'll tell you why. There was a guy who wrote a paper once saying that the levator valli palatini also, for a different reason entirely, can somehow open the auditory tube. And maybe, in fact, this is just a conversation between me and Dr. Larson, that if, in fact, the levator can contribute to opening the auditory tube, then that would allow, once you've improved the drainage by the downward slope, that would then allow you to avoid those problems. I bet you that guy may be right. All right. So now the muscles, the five muscles that actually do move the jaw. Just to orient you here, obviously is the mandible, the lingula, to which something called the sphenomandibular ligament attaches, actually a very important ligament, because it sort of keeps the distance, not sort of, but does, keep the distance between the lingula and the sphenoid bone, or the spine of the sphenoid bone, in place, in position, so that you can never move this point very far away from the base of your skull. And you don't want to move this point very far away from the base of your skull because you have the inferior alveolar nerve going there. So you don't want that nerve to be stretched and sheared and things of that nature. So you keep that distance between the lingula and the base of your skull fixed with the sphenomandibular ligament. And then there is the jaw joint itself. The condyle of the mandible sits in a depression here called the articular fossa. I know your book calls it the mandibular fossa. That's probably its correct term. Most head and neck people call it the glenoid fossa. I don't know what glenoid means. You know what glenoid means?
It's like some shape. It's like a boat shape.
Boat shape? All right. Doesn't look like a boat. Neither does the other glenoid. There's another glenoid fossa in the shoulder, too. Doesn't look like a boat. But anyway, I don't care what fossa, what you call it. All right, mandibular fossa, glenoid fossa, articular fossa, the jaw joint. But that's where the condyle sits. And then there's this big bump in front of the articular fossa called the articular eminence. Very, very important in mandibular functioning. And then there is, in this joint, unlike other joints we've looked at, there is something called an articular disc or an intra-articular disc, a fibrocartilaginous structure interposed between the condyle and the cartilage of the articular fossa and articular eminence. You might think, that's what the big no means, don't think this. You might think that an opening and closing of the jaw, a line between your mandibular condyles would represent the axis of opening and closing. But in fact, you can prove to yourself that that isn't true by putting your fingers in front of your external auditory meatus and opening and closing your mouth. And you should feel this bump riding downwards and forwards and backwards when you close. And that bump you are feeling, moving, is the lateral pole of your mandibular condyle. So if the mandibular condyle is moving downwards and forwards when you're open, and backwards and upwards when you close, it can't be the axis of rotation because the axis is, by definition, something that doesn't move during rotation. So you've just proved it can't be the axis. But let me show you this video, which is really nice, how this jaw joint really works. This is where the real axis is. It's not even in one fixed place. It tends to move about this area just posterior to the angle of your jaw.
This is a sagittal section of the right temporomandibular joint. Here you can see the condyle, the fossa, and the tubercle. This is a disc. And here you have the upper joint compartment and the lower joint compartment, filled with blow water in order to stabilize the disc during sectioning. The soft tissue cover on the condyle is thin. This is probably an artifact. And it's also seen in the fossa and somewhat thicker on the tubercle.
Yes, you notice how much thicker the cartilage is, that's he's pointing, on the articular eminence, because that's where the force, because there's always a force between two bones at every joint, that force is going to be transmitted through the cartilage of the articular eminence.
The posterior band of the disc is situated superior to the condyle. The posterior attachment is a little bit thinner and longer than seen in an absolutely normal joint. The lower head of the lateral pterygoid muscle is seen here, and this is the superior head.
This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment.
All right, so you see that condyle actually moves, and it really beyond what's the opposite of an apex? The lowest point of the articular eminence. Your condyle moves pretty far on the articular eminence when you open that jaw. It can, in fact, move beyond that into a point of dislocation in front of the articular eminence. That is, not everybody, but some people, if they yawn, go into a very extreme yawn, their condyle will not only ride down the articular eminence and even beyond its apex, but it'll snap back into position in front of the eminence. I don't know if you ever saw anybody like that. You have? All right. So then come and tell us what you do.
All right.
Because I've never seen anybody.
If you just stand still for a second. What you do is, so the jaw is forward and they can't close it. They'll have a prominent underbite. In other words, they'll be like this and they can't close their jaw. What you do is you take your hands and you put them in. Now, this is not something that I'm trained to do, but it's something that I've seen done. And anyway, in other words, it's not in the scope of practice typically pre-hospitally, is you put your thumbs behind the teeth because you don't want to get bitten when the jaw clamps back over, and you just pull straight down, and the ligaments will actually reorient the jaw posteriorly and superiorly back into the joint, and there are different techniques to prevent you from injuring them or injuring yourself when the teeth reclose, because it can be kind of rough, but that's it.
I thought, Thomas says you just pull straight down. I thought you push downwards and backwards to force it underneath, force it down the eminence and back into the fossa again. It's supposed to be, and the only person I ever knew who had this happen frequently claimed she was never in any pain when it happened. But I was told that it was a terribly painful condition if your jaw disarticulates that way. And as Thomas told you, you have to put your thumbs behind the molars, because when that jaw does go back, it snaps shut. And otherwise you'll be like a gibbon or something like that when you're through. So, yes?
Do you know what causes TMJ, like the snapping of the jaw in a lot of people? Is that because there's not enough cartilage?
Can you wait? Yeah, well, there's a variety of explanations. I mean, obviously it's a dissociation between the motion, not obviously, a dissociation between the disc, proper movement of the disc and the condyle leads to TMJ problems. Sometimes, and if you wanted to go to this video, there are about 6 segments, which I edited out, of examples of disc problems. Sometimes the disc gets partly trapped, and they say that when it bounces back, it makes a little noise. Sometimes they say it's due to the joint being pulled apart, and whenever you pull synovial fluid subjected to tension. It makes a little cracking noise. So there, and you're going to see an example of an extreme version where the disc is completely extruded when we do the radiology section of the course. There can be lots of things happen to this disc, and can be partially extruded from the joint, completely extruded from the joint. Most of those start out with clicking noises and then move on from clicking noises to pain. There's a lot of literature on it, which I'm not totally conversant with, but you can, if you wanted to read about it. All right, so the 5 muscles that actually do move the jaw, knowing now that the effective axis of rotation is somewhere here behind the angle of the jaw, we can figure out, in relationship to this axis, what these muscles are likely to do. Here's the anterior belly of digastric. It's not a very powerful muscle at all. The vectors I've drawn here are not, the magnitudes are not representative of anything. It's just the direction. But if you imagine a pull on the inner aspect of your chin posteriorly, it will exert around this axis a clockwise rotation as we were looking at it. So this will be an opener of the jaw. But the most important opener of the jaw is not the anterior belly digastric, because you really don't need it to open your jaw, and it's not powerful. It is the inferior head of the lateral pterygoid muscle. Again, if you imagine a pull forward on the neck of the mandible, and you draw the leverage it exerts around this axis, it will cause a clockwise rotation of the mandible as we're looking at it. And that is, in fact, the major muscle which opens your mouth or lowers or depresses your jaw. The masseter has a different kind of leverage around this axis. You draw its lever arm, and it's going to cause a counterclockwise rotation as you are looking at it. So the masseter is a muscle which closes your mouth, elevates your jaw. Medial pterygoid, seen here on the deep surface of the mandible, is another muscle with almost the same vector pull as the masseter, and causes a counterclockwise rotation around this axis and elevates your jaw or closes your mouth. And the temporalis, which pulls upwards and posteriorly on the coronoid process and has the same effect as masseter and medial pterygoid, causing a counterclockwise rotation and closing your jaw. So we have these 3 jaw closers, temporalis, masseter, and medial pterygoid, and 2 jaw openers, inferior head of lateral pterygoid, the most important, and anterior belly of digastric. And then we have this other muscle. It's not another muscle. In fact, some people say it is another muscle. There was a series of articles maybe 15 or 20 years ago who said that the superior head of the lateral pterygoid should be considered a separate muscle and be called the superior pterygoid muscle. And the reason they said this is not only does it arise from a different part of the sphenoid bone than the lateral head, and has a slightly different insertion, but it's not really very different. But the main thing is it does not contract when you open your mouth. Superior head of lateral pterygoid contracts when you close your mouth, and particularly when you bite down hard on things. So its function is 180 degrees opposite from the function of the inferior head of the lateral pterygoid. And most people believe that what the superior head of the lateral pterygoid is doing when you bite down hard on something is pulling your condyle forward so that the force is directed between it and the articular eminence, and not between it and this roof of the articular fossa. Look on your skulls if you have a real skull. The roof of the articular fossa, you may have even remembered from that video, is very, very thin bone. And all that sits above it is your temporal lobe of your brain. So this bone here in the roof of the articular fossa is incapable of essentially withstanding any major stresses. And so the idea is that the superior head redirects the transarticular joint forces between these 2 bones so that it always passes between the condyle and the articular eminence and never passes between the condyle and the roof of the fossa. Now, we looked at these muscles in lateral view here, but I want to point out to you that quite a few of these muscles, all of them really, have major vectors in an anterior and posterior, major components of vectors in an anterior and a posterior direction. And let's just look at the anterior-posterior components of vectors of 3 of them by looking down onto the surface of a mandible. Here's the condyle, here's the coronoid process, and obviously the body with all the teeth. Here are the anteriorly directed components of your medial pterygoid, your masseter, and your lateral pterygoid shown in a different color because it's a jaw opener, whereas the medial pterygoid and masseter are jaw closers. But you can, in fact, contract these three muscles simultaneously on one side. And if you contract these three muscles simultaneously on one side, the jaw closing and opening effects tend to balance each other, and you are just left with the effects of the anteriorly directed components of their vectors. And what happens is the jaw deviates to the opposite side. I like this. This is just this year. It's the first time I created this. All right. So when you use your right-sided masseter, medial pterygoid, and inferior-headed lateral pterygoid, your jaw deviates to the opposite side. Now, depending upon how, if you contract your lateral pterygoid a little more, it opens a little more. You contract it a little less, and you can get a pure lateral deviation. These three muscles are what are the major deviators of your jaw to the opposite side. If you contracted your lateral pterygoid on one side all by itself with no masseter and no medial pterygoid, your mouth would open but would deviate to the opposite side. And this actually forms probably the basis for the best motor test for the trigeminal nerve. I'll show you our friend testing it.
The motor mandibular branch is tested by jaw closure and opening. Ask the patient to clench their teeth and feel the temporalis and masseter muscles contracting. As well, ask the patient to open their mouth and then do so against resistance. Keep your mouth open, and the mouth should remain firmly opened and not deviate to either side. You can also test lateral movements. Enrica, move your mouth to the right against my hand with the jaw open, and to the left. And strength is normal. If there was weakness, the jaw would deviate to the side of weakness. The final aspect that can be done as part of the V3 is a reflex. It's known as the jaw jerk, and this is done by gently tapping on the jaw. So you want to explain to the patient, I'm going to tap on your jaw, and I'm going to put my fingers like this on your face. I want you to kind of let your mouth hang open. Support the jaw with your fingers. Enrica, I'm going to hit my finger. Just try and relax your jaw and let it hang. Deliver a downward blow with the reflex hammer. And in fact, Enrica doesn't really have a jaw jerk. You're seeing the stimulus being transmitted, but the jaw jerk, there'd be a bit of a delay and the jaw would come up.
I showed that to you because Enrica didn't have a jaw jerk, and I've never seen anybody else do that. Do they? No.
I think I misspoke earlier. You asked if we do a corneal reflex.
Yeah.
We do not.
You do not? Yeah. All right. So you won't be taught to do a corneal reflex in a standard exam. I've never seen one do a jaw jerk either.
Don't think they trust us enough.
In an exam. But I mean, obviously, the rationale behind palpating the anterior temporalis, and you do it right behind the orbit, which is the only place you can feel it, really, or palpating your two masseter, is you hope to get a sense of whether one side is weaker than the other. I tried, I guess when I was talking about smell, more important than anything else. In all of these exams, you're looking for a difference of one side to the other. Because if people are just uniformly weak on both sides, you're not going to learn anything. You're always looking for an asymmetry. So you can do it by palpating, but in fact the best way to do it is this lateral deviation of the jaw test. Because then you're actually measuring strength, and you can get a real sense of weakness. Not just, and complete paralysis is easy to figure out. Weakness is more difficult, and you get a sense of weakness if you ask a person to deviate their jaw to one side and you push, and then the other side and you push, and you can see whether one group of muscles on the right side is weaker or stronger than the group of muscles on the left side. And of course the muscles you're testing are the ones which have these important anterior components to their vectors, the masseter, medial pterygoid, and lateral pterygoid. What happens, I said nothing happens, or at least I never found any description of symptoms when tensor tympani, tensor veli palatini, and myelin hyoid are paralyzed. Are there symptoms when your jaw muscles are paralyzed on one side? And the answer is yes. There are big symptoms when your jaw muscles are paralyzed on one side. And even if the difference is subtle, let's say it's not a complete paralysis, but it's just the beginning stages of a disease, and the person just has weaker jaw muscles, you are so sensitive to the way your teeth fit together in normal life that the minute one side of your masticatory muscles becomes weaker than the other side, you will sense that there's something wrong, and you will sense that your teeth aren't fitting together well. And of course, as it progresses, then obviously you have a lot of difficulty chewing on that side. And every time you open your mouth, if I have a paralyzed right-sided masticatory system, my jaw might be in a normal position at rest, but every time I go to open my mouth, it'll open to the side of the weakness, because only the intact muscles are able to contract, and their anterior vectors are completely unbalanced by anterior components on the side of the paralysis. So it always deviates, as she was saying, to the side of the paralysis. Okay, that's the end of this.